Hello, everyone. Welcome. You've made it to part 3 of our recovery series. Before we dive into our conversation today, we've got a few short polling questions for you to kick us off. So we're going to go ahead and launch the first one. So go ahead and answer that on your screen. Give you 5 more seconds.
Yeah, call back.
And a really good mix of folks on the line today. So thanks so much for joining us. Second question. Go ahead and answer.
I don't see it.
Five more seconds. About 90% of folks joining us today are from urban areas. Question number 3, go ahead. Five more seconds. All right, 80% of folks are calling in from BC today. Five more seconds. And about 50% of you are saying that COVID-19 has impacted your recovery journey. And final question for you today.
Yep. Well, I've clicked on them.
Oh, sorry, if you could go ahead and mute yourselves, presenters. We're not quite ready to start. And 5 more seconds for this last polling question. And about just over 60% of folks are answering this question with somewhat accessible. So that'll help guide our conversation for today. So we're going to go ahead and get started here. I'm just going to pull up my slide deck. And so, as I said at the very beginning, you've made it to part 3 of the recovery series. And so if you were able to join us, part 1 talked about maintaining and initiating recovery. Part 2 was all about the awareness and celebration of recovery. And now part 3, here we are today, talking about health systems and public education. So welcome to everyone, and so glad you were able to join us. Before we kick it off, though, taking this moment to reflect on the knowledge or on the land in which we're sharing and exchanging this dialogue today. And so on behalf of my colleagues on the Lower Mainland, we're recognizing that we're on the traditional territory of the Coast Salish people, including the unceded homelands of the Musqueam, Squamish, and Tsleil-Waututh First Nations. However, with any of our webinars, we invite people to come from all over the province and even all over Canada. And so take a moment now to reflect on the lens in which you're listening in from and the work that you're doing, and just give your thanks and acknowledgement on where you're at. With that, we're going to dive right in. So as I said, this is part of a larger series So we're really bringing together thought leaders, healthcare providers, policymakers, people with lived and living experience, families, so we can all come together to have these conversations about a full continuum of care and the options available to folks with substance use disorders or their recovery journey. So here's a bit of an overview of today. As with the rest of this series, we do like to do a bit of an introduction, but then we dive right into some panel discussion. So we've got some juicy questions for you. We're going to hear from our panelists, but then of course we want to hear from you as well. So in your panel, you'll be able to see a questions box. So you can go ahead throughout this entire presentation. You can go ahead and list those in there, and we will get to those questions later on in this presentation. But with that, I'm going to introduce our interview guests today. So we have a number of them, and they're just such experts and will bring such a wealth to this conversation today. But we'll start with Julian Summers, who's a professor in the Faculty of Health Sciences at SFU. And Dr. Summers is a clinician, scientist, and scholar specialized in addiction. He has led initiatives in BC and the Yukon that integrate the prevention and treatment of addiction with primary health care, criminal justice, housing, and mental health services. Then, of course, we have the amazing Leslie McBain, who is a co-founder of Mom Stop the Harm and a very valued member of our stakeholder engagement team at the BC Centre on Substance Use. Leslie's story is incredibly powerful. She lost her only child, her son Jordan, at age 25 in 2014 to an accidental overdose of prescription drugs. In 2015, she met two other moms who had lost their sons to drug harms. Over a year, they created the organization Mom Stop the Harm in order to support the lives of people who use drugs and their families. Leslie's work does not go unnoticed. She's such a champion and powerhouse for the support of families and people who use drugs in British Columbia, and very lucky to have her on the line today. We also have Susan Hogarth, who's the Executive Director of the Westminster House Society, and she's a member of the BC Addiction Recovery Association, the Treasurer for Recovery Day BC, and is currently studying her Master of Business Administration. We also have Gloria Harding, who is bringing to us her wealth of lived experience. And so she's an Indigenous woman, originally from Pavine Métis settlement in Alberta. She currently resides in Prince George, British Columbia, so representing the North. Thank you, Gloria, and has been in recovery and abstained from alcohol and drug use for 33 years. She has a diploma in mental health and addictions counseling and currently finishing a Bachelor of Arts program in business leadership with Athabasca University online study. As with our whole series, we have some panelists who also offer their expertise. So no strangers to this series is Jessica Cooksey, who is the operations manager at Last Door Recovery Society, as well as Carson McPherson, who is the executive director at Cedars at Cobble Hill. So I'm Amanda Giesler, and I work at the BCCSU leading our education activities, and I am co-moderating this session today with Giuseppe Ganci, who is the Director of Community Development at Last Door Recovery Society. And with that, I'll pass it over to you, Giuseppe, to take us through our juicy discussion today.
Okay, thank you so much, Amanda, and thank you for acknowledging the land that we are on, and for the introductions of all of our speakers, and welcome to all the attendees. Thanks for taking some time out of your busy day for part 3. And I'd like to start off for this webinar. A lot of questions have arose in the past on what is recovery, and we really want to keep it simple during these talks. And what is recovery? Recovery is a journey towards improved health, function, and happiness. And we acknowledge the many pathways to one's recovery journey. There's not one size that fits all. And on a personal note, I don't think there ever will be. And the reason why we're doing these conferences is to help strengthen the conversation about recovery during the crises of homelessness, poverty, fentanyl, and the overdose crisis. On that note, I wanted to start off with Leslie from Mom Stop the Harm. Hello, Leslie.
Hello. Good morning. Good afternoon.
Hi, good. Yes. Good afternoon. Leslie, we'll start off with. I think everybody knows what Mom Stop the Harms are, but maybe some people don't or have their. Can you please explain to us what Mom Stop the Harm is?
I can. It's Mom Stop the Harm is a national organization. We started the three women, 2 other women and myself started it in about 2015. We have our primary goal when we started was to improve and look at and improve drug policies that would support people who use drugs. Our vision was to keep people who use drugs alive, until such time they could go to recovery if that's what they wanted. We have evolved a little bit into also support now. We have two projects, one called Healing Hearts for families who have lost a loved one, and another one called Holding Hope for people who have a loved one still struggling. And so those have become more and more important. We have a good presence on social media and so on. So we advocate for better policy, and we also support those people who are in some kind of pain around the drug harms.
About social media presence, Moms Stop the Harms currently and has been very strong in having the conversations about prescription drugs, safe supply. Leslie's an advocate for easier access to such policies. We don't want to talk about the prescription safe supply drug policy as in the merits of it. There's lots of BCCSU webinars on that, and please take a look at the website for more info. I wanted to talk to you about recovery in that policy. How does it fit in? Should it fit in? Is it fitting in? What are your thoughts on that?
So I assume we're talking about the risk mitigation during
documents. A lot of people are so polarized. It's like safe supply isn't recovery, recovery isn't safe supply. There's a lot of conversations going on. So and some people think that they don't support each other. And I'm asking you, like, do they support each other? Support each other, and how we're doing?
Yeah, I think we are all heading in the right direction on this. And the way I look at it, and the way Moms Stop the Harm looks at it is, and we said this at the beginning, and we still say this, it's so obvious, a dead drug user will never recover. So the risk mitigation policy of rolling out safe supply in a limited way is a way to keep people safe from COVID, so that they don't need to necessarily congregate and be in unsafe situations. And it's also a way for people to have safe drugs that they need. So so they'll stay alive. So I think we take the position of people staying alive, people staying healthy. And then when it's time, when they are in a place where they feel like heading towards recovery, we hope everyone recovers, obviously, and so we want there to be options. And the reason I think these things work together is because the touch point where drugs are meeting the safe supply is also a touch point where they may find information on accessing recovery options. So I think it's really, really important to keep these things together and to not have any kind of them and us, or we're all in this together, we're all going the same direction.
We're trying to make sure that someone's there at the end of the day to access recovery. You've been to many conferences, I've been to many conferences. There's harm reduction conferences, there's the Recovery Capital Conference, and there seems to be this, if you go to a harm reduction conference, it's about harm reduction, and recovery is kind of on the side. We do a Recovery Capital Conference, we got Portugal there, we got Switzerland there, and it's considered a 12-step abstinence only. Why is that, and how can we change that with education? How can we make everything inclusive?
Well, I think that the reason for the break is a historical one, and because we in the past thought of recovery as 12-step abstinence-based, period. That was it. And what I know just from my 6 or so years of being in this area is that works sometimes. And so I think that historical break is there, and it also was often faith-based, which didn't work for a lot of people, and so on and so forth. But what I've seen in the past couple of years is the recovery community going more towards evidence-based recovery, going towards a loosening of those of a lot of those strict rules in the facilities. And what we moms say is we're really into redefining recovery to include, so that the public actually gets it, that each person who wants to recover is like, it's like their fingerprint, right? It's unique. Everybody has a certain set of reasons why they got into addiction and are staying there. And the treatments around that have to be broad, low barrier, evidence-based, and whatever the person needs to be sort of triaged first. Just a second, sorry.
Someone has a friend there? Yes. Okay, Leslie, we'll come back to you towards the end with some more questions and some summary. We're going to move on to Dr. Julian Summers. Hello, Julian. How are you? Hello.
Hi, Giuseppe.
Mic's on. Perfect. We had a camera scare there, but we fixed it. Julian, if I may, what does the research say about recovery in health systems?
It says, sorry, I'm going to adjust maybe that'll help. In health systems, it says less than, sorry, I've still got an audio problem.
Sorry, Julian, if you have your phone or another device that's also on, maybe mute one of them, that might help you.
Okay, sorry, I'm very sorry about this.
Nope, can't hear you now. So,
Julian, you may want to phone in.
How about now?
yep, we can hear you now.
Okay, so thanks. Sorry about that. I think that there's a bit of a limitation in the question, if I may, Giuseppe, by framing it within the health system. Because most recovery, the vast majority, if we mean by recovery people having serious problems of addiction, whether they're substance-related addictions or what we call process addictions, and then at a later point are no longer troubled by those, by their own standard and by somebody that would objectively confirm that, most of that doesn't happen with any involvement of the health system. So there are many cases, and I don't want to get into quibbling about percentages so much, but substantial numbers of people overcoming problems ranging from smoking to opioids, we know historically have done it without treatment. An interesting thing is that people in the health system for decades said, no, that didn't happen. And then if it did happen, they weren't addicted in the first place. So there's been a tremendous sort of resistance to the idea of recovery, whether on its own or with assistance, precisely from within the healthcare system or among health professionals. And of course, on the justice side, it's been a disease that requires some kind of rehabilitation, possibly mixed with punishment and threats. So I think that it's the framing of the issue in part that I agree with Leslie historically that's gotten in our way.
So there's many conversations online, on Twitter, where because there's this polarization, the conversation sometimes leads to, I mean, it's plain black and recovery doesn't work. And so when those conversations happen, the research and the evidence shows that recovery does work. Why do you think, like, what are the numbers in regards to recovery? I mean, we've gone down a route where this polarization has happened because of social media. So we take a look at, for example, the new drug policy and housing first. Are we at a place where this is going to help with recovery, or do we have to do a lot more work? What's the evidence say in regards to the housing situation we're doing with the people that use substances?
Yeah, so thank you. I mean, this is a population that I've spent a lot of time working with. My view on what's sort of happened in the last 50 years, I'd say, is that we've gone from this tension around medication. There's always been a tension, mostly within the medical and pharmaceutical fraternity from about 1900. Whether or not medications should be used in the treatment of addiction, to what extent, and it was always whenever it was done, it was always very, very gradual. for limited periods of time and conceived as a transitional aid. So not everybody needed it, but for some it was acknowledged that, yeah, some people are going to need this, and along the lines of what Leslie said, as a way of getting people connected. However, make no mistake, the goals of treatment when methadone maintenance was introduced were becoming an integrated citizen, being connected with your family, being connected with work, having a meaningful life by your own standards. That's the goal, and being done with narcotics, right? As I said, they were meant to be transitional. So in the meantime, I think what's happened, to boil it right down, is that there have been more and more factors in society that cause addictions, that cause people to be to have lost their way. It's no surprise that BC would be one of the central places on the planet for addiction. We're all newcomers, right? We're the largest geographic area that hasn't resolved situations with the indigenous people, right? Any surprise people are at a loss? And what about mental illness? One of the other big on-ramps to addiction among people I see. We have a terrible tertiary mental health care system. It's lost in transition, as the Vancouver Police Department have said. So ways out of addiction. Absolutely, providing people with housing, and you touched on housing first. If we respond to people where they are, and I think I'm not actually adding anything to Leslie's comments. She covered everything. But if we start with asking people where they are and what they want, people have written about this, published it. They'd like housing, they'd like assistance finding work. A minority say that as part of their treatment plan or whatever can be provided to them, that they want medication. But there are some. But importantly, it's a minority. And I think we go too far the other way if we suggest that, well, the on-ramp for everyone is going to be some kind of medication-assisted treatment. That's actually an equally potentially damaging misread of the evidence. Starting with people where they are, providing them with those means of joining society. Part of the reason we're stuck, I believe, is that there is no constituency, no profession that has evolved over time whose job that is naturally. Medical doctors don't do it, and the justice system doesn't do it either. And we've been distracted by squabbling, forgive me, but disputes back and forth between professions over I got this, and neither of them are actually capable of resolving the problem, because it involves a different view of the person than a problem that resides within them, either because they're morally depraved or physically ill.
Wow, that is a great viewpoint. Thank you so much, Dr. Summers. We'll definitely come back to you in a bit. We're going to go on to the next speaker, Susan Hogarth. Hello, Susan from Westminster House. Hello.
Hi, everybody.
Susan,
Hello.
you work with women on a daily basis, and I wanted to talk to you first off, firsthand experience. What are some of the challenges that you see on a daily basis for women accessing recovery support services?
Yeah, thank you. That's a great question. And I just wanted to thank the BCCSU and Amanda yourself for inviting me to participate today. And I really appreciate what everybody has said so far. But firstly, I'd like to point out that nobody really wants to pay for their health care, and nor should they. And this province inadvertently, through the opioid overdose crisis and before that, have built this two-tier healthcare system where the haves get, private treatment and the have-nots get waitlisted. And those are challenges that we see every day. And I also have to point out another misconception in this province is that there's a shortage of beds. There's not a shortage of beds. There's a shortage of funding for recovery, and there's the inability to pay for the government to pay for the beds that we have available. And those are challenges that I believe both men and women have in accessing services right now. With women, it's often hard to have women commit to leaving their children behind. Although I believe in a lot of circumstances, it's better for the children of an addicted parent to seek help, that they should seek help and leave their children behind so they can take care of themselves. So that works well for us here. Another thing that's really difficult and challenging is the confusion of the messaging. So women are told it's okay to use drugs safely, leaving them in a place of denial, and remembering that denial is the #1 reason why individuals don't seek help. And so the challenge is that these addicted women can barely look after themselves. Then they're saying you can use safely, then they can't parent lose their children. So we see a lot of that coming in, a lot of that confusion as to what's the right thing to do, what for everybody. We know that the science of addiction says that, the more drugs are used, the more drugs are needed. And I think though the safe supply is needed, it has to be in a continuum of care. And we've spoken a little bit about that. And, we know that in order to access treatment, a lot of people do need a medical intervention. Some don't. They need to come into treatment, look after themselves and take responsibility and change some of their behavior before they can go on to parent and look after houses. You have to remember, a lot of addicts, they can't even look after themselves. And when they're put in a situation when they're given housing before their disease has been treated, it's a real setup. And it can also set women up for sexual exploitation. We know, I'm a person with lived experience. I'm also a family member of a child who's on the downtown east side. So we know how hard it is to stop using drugs. You'd have to be a drug user to know how hard it is to stop. And we don't talk enough about that. I believe safe supply is great. A lot of people are going to take advantage of it. I know a lot of women that, they just use that, as an interim until, they can pick up a trick and score some illegal drugs. That's something that we see here all the time. And I'd say 80% of our opioid users who come into treatment at Westminster, that's their story. We picked up our methadone in the morning, we picked up a trick at noon, we picked up fentanyl in the afternoon, and the evening we were committing petty larceny. And that's like a typical day in the life of a woman that's, struggling with addiction on the streets. It's just a painful experience. So I strongly believe in safe housing, but my strong opinion is that the current strategy is in the wrong order, and we need housing, but we need housing within the continuum so that we can save these women's lives. And they're just at great risk when they're put into housing with proper supports around them. So that's kind of where I'm at today. I don't know if it answered your question.
So Susan, I wanted just to all of our attendees, please note that recovery is not treatment and treatment is not recovery. Recovery support services can be treatment and many other things. So now we've got women of a vulnerable population that you're talking about. What are some of the ways that you initiate recovery in those people?
We've done a lot of interesting things. We get phone calls all the time. We have teams of people. We had a phone call from a 15-year-old girl in Oppenheimer Park, and their family was just frantic. And this girl was taken to the safe injection site on a daily basis by a 40-year-old man and given drugs every day. And we actually went down to Oppenheimer Park and got her. That would be an extreme case. Other than that, to access treatment, there's different ways. Of course, people who want to privately fund treatment and recovery, they can get in pretty quick. People who don't have the means and have to go through the portals that are set up by the health authority that have actually just increased barriers to access healthcare. So there's lots and lots of different ways. We talk about people that are using it in the using group, and I appreciate everything that everybody's said, but one thing that's not happening is that when somebody comes in for help, they're given, medical interventions, but recovery isn't even in the conversation. If nobody says, hey, have you thought about going to 12-step meeting? Like, parents aren't told to do this. Parents are like, if your child is struggling with addiction, take them to the doctor and the pharmacy. Not take them to a 12-step meeting. Take them and talk to some people who can help them figure this out. And so I really hope that, like, the future of mental health and addictions looks like when somebody comes in and they're in trouble, providing them with all the options that are available. Like you can go into housing, you could go and seek recovery in smart recovery, you could go and seek it in a 12-step base. Maybe you need to access treatment. Maybe you have to find some housing for your child so you can access treatment. Maybe 12 steps are enough. Maybe acupuncture is enough. You just don't know, because everybody, we often talk about meeting people where they're at. And that's a really strong messaging as well, because not everybody needs to go to treatment, and a lot of people do and a lot of people don't. So it's like, how do we find out? We have to figure out a system of care where when somebody comes in and asks for help, all the options are available to them there at the time. And have somebody who's got some knowledge about addiction say, like, I can see, you're working the street or you're robbing banks right now. Maybe right now you should be in residential treatment. And maybe it's another person that I can see you're at work and you're sneaking sips of your vodka at lunchtime. Maybe you need to go to a 12-step meeting. And there's all different ways, and it's like finding the way to recovery and being.
I think you're exactly right, Susan. I mean, we talked to our personal story last week. She was on medication and had a clinic that she went to downtown, and was never told about recovery until she got and met people in recovery. And this is why we're doing these talks, and the BCCSU has acknowledged it too, that the conversations sometimes are so siloed thinking. We have lots of stories where someone went to works at a youth drop-in clinic and was told to not talk about recovery to any of the youth, and no pamphlets or information about recovery because it's a harm reduction clinic. And so we're trying to break down those barriers where recovery needs to, absence-based recovery needs to acknowledge harm reduction and all the pathways, and vice versa. And I think by us all talking our stories, we can see that there needs to be a lot of work done to make sure that the full continuum of care is available to everyone, despite their financial capital and if they have a credit card with funds on it. Our next conversation is going to be with Gloria. Hello, Gloria. Gloria has a lived experience not only personally with recovery, but also professionally. And I wanted to maybe lay the framework for our attendees. Gloria, how did you make it to be on this panel to talk about lived experience?
Well, I was invited, and I want to thank the people that invited me. And also, I've been in the recovery community for 33 years, and I've abstained from all alcohol and drug use. I began my journey in 1986, and at that time, I was accessing a methadone program. And my personal background is, my mother was in the residential school, and I was in the Catholic day school. And there was a lot of trauma in my family and a lot of addictions. A lot of my aunts and uncles have passed away from liver disease, from alcohol and drug use. So, that was sort of the way we lived. You get this acceptance of violence and trauma, and that's life. And when I went to the methadone clinic, I was about 3 months pregnant. So I stayed on methadone the entire time of my pregnancy. And my son was born addicted to methadone and heroin because I was using both. Methadone never stopped me from using heroin or cocaine. I continued to do like a cocktail my entire pregnancy. And at that time, one of the counselors at the methadone clinic, I had heard about NA because there was pamphlets there. The counselors would talk to us about options, and I started to ask, I want my child returned to me. What do I do? Where do I go? And she referred me to a treatment program and said that I had to go to detox in order to attend it. So I went, and she said, you can stay on a minimum dose of methadone, but you can't use. And I guess I had a moment of just a spiritual experience where I said, I know that if I'm on methadone, I will use, and I know it. There's no other way for me. If I'm on one thing, I'm going to take the other. and I'm not going to move on from the people I'm associating with. So I went to detox, and my life started over, and I was able to access services right away. I went to a recovery house right away while I waited to go to treatment. And then after treatment, I went back to the recovery house until I had about almost a year clean and sober. And then I was able to take care of my baby. Definitely in my recovery, I've had to deal with mental illness. You know, I honestly believe today, you know, I have no regrets about using drugs, because if I hadn't, it would have been a loaded gun to the head. In my recovery, I experienced a lot of depression and anxiety and was diagnosed with that, and I've been treated for that. I've also accessed therapy and cultural healing practices in my journey.
Gloria, I wanted to ask you, is 30 years ago, your personal experience accessing recovery seems to be the continuum of care is working for you, and you're on methadone and you get referred to recovery support services, and it seems like the ball gets rolling. Now you work in the field, you work with many youth, Indigenous communities. What is your professional experience now with accessing recovery support services today? Is it the same from 30 years ago? Has it changed, and how so? Better?
Well, it's significantly changed. I mean, there is, you know, the thing about saving lives and dealing with people where they're at. And I don't believe there's ever an intervention that's too soon or too late. And working with people that are still, you know, suffering with mental illness and addictions needs to begin from the moment they ask for help. You know, why wait till they're ready, so to speak? And you know, we can get them ready, we can inspire them. And you know, all the elders that have ever worked with me, or that have worked with my clients, they are clean and sober. I've never had an elder come in and say, well, I'm going to help somebody, but I'm drinking every other day or on the weekends. You know, there seems to be a real high regard for sobriety for elders. And my aunt, she's 75 and she's a Métis elder, and that's how she lives her life. And that's had a real positive impact on youth, you know, having role models in their own community, having people they can turn to and talk to. And, you know, a bit of kindness goes a long way, you know, and this is about love. You know, healing is about love and a sense of belonging, and feeling like you're a valued person. And I know from working in the downtown east side, a lot of the folks that I work with, they felt really devalued, you know, not wanted, not cared about, not loved. And I think when we bring people in, you know, we're not bringing them in to recovery to shame them or make them feel bad about what they're doing. This is about telling them, I understand why you're doing what you're doing. And I don't think that there's a person, like I've had young people come up to me that are like support workers in an organization telling me about how harm reduction is and how to treat addictions and how to do this and that. And I just think to myself, man, if you knew where I had been. And I don't say nothing because it's like, well, you know, you've never experienced what I've experienced and you don't have my education. But if you think you know what to do, go for it. But what I do is I just keep it real with people. And at one point, the treatment centers were doing mobile treatments into remote communities, and there's no more funding for that. And I think that that's a real blessing. You know, like, yes, we want to educate the community members on harm reduction and safe practices and safe supply, but we also want to make things accessible. And when I was working in communities, when I would do a treatment center referral, especially at treatment centers that have a trauma-informed focus, that work with trauma, there would be a really long wait list. And then a lot of the folks were really afraid to leave their community, you know, get on a bus and go down to Vancouver Island. And, you know, it's really frightening, and you don't know where you are. And, you know, and it's easy to get lost. And
definitely localization and accessing when somebody's ready to access support services. Just like when you break your leg, you can go to the hospital right away. You don't have to wait. Hopefully one day that's the same with addiction and recovery. We are now going to introduce, thank you, Gloria. We'll come back to you with a summary and maybe some more questions. We're going to bring Jessica and Carson to the discussion. And we're going to start off with Carson. A question was sent to us, and there were many questions with this theme, so we decided to add it to the deck of Q&A. There will be a Q&A after. You can add the questions to the Q&A chat. The question is from someone who has asked, many people initiate their recovery by attending an inpatient addiction treatment center. However, some people encounter barriers in initiating their own chosen recovery pathway because most treatment centers in BC or in Canada are 12-step based, and that's mandatory. Carson, I wanted to bring that to you. What do you think of this question and making treatment centers comply to not being 12-step? What are your thoughts there?
Yeah, thanks, Giuseppe. You know, it's an interesting one because I think there's some pretty loaded assumptions built into this question. You know, while many do access residential care, most don't. You know, and when you think about resources, I think Julian hit it right on the head. You know, we're constantly talking about a healthcare system and looking for that healthcare system to respond, but realistically, you know, the challenges with addiction and what mobilizes people out far supersede the traditional boundaries of our healthcare system that we know. When you think about, you know, the inference that you know, 12 steps is sort of the mandatory one and only approach of treatment centers, I can speak anecdotally from my experiences, and I know most of the providers, at least in the western part of the country, and I would say that's you know, that's maybe a historical truth from years gone by, but that's not what I experience now. But in saying that, I want to be really careful not to say that, you know, this has been some type of adversarial or advocacy push for treatment centers to move away from 12 steps. There's a ton of evidence, and I know Julian will get into it, and you know, I don't know why we say there's a ton of evidence to support 12 steps. But if you step outside of the evidence and think about what's going on, you know, I think I talked in the first one about you know, we misinterpret motivation for clarity. Right? We think that someone's not motivated to receive help, and really they just don't know how. And think about the practical logic of a 12-step program, right? And I feel like there's a weaponization of the faith-based component. I think we can all agree, you know, a program designed in the 1930s has probably got some antiquated concepts in it as society has evolved. I don't think anyone's going to deny that. But fundamentally, you're learning the boundaries of a disease, which it very much is, a primary disease. You're learning a lot of soft skills that go along with it that we don't talk about, right? The friendships that go along, the new social actors in one's life that can show someone how to have fun in recovery, which is one of the biggest challenges for folks. How do you live this way without, you know, drug, alcohol, or process? You know, how and the inference of you know, of centers that are mandatorily pushing this down. I think it's also one of the challenges that we have in British Columbia, and unfortunately, a lot of what we do tends to transcend our provincial boundaries. But we focus so much on the Vancouver area, and of course, if you look in Vancouver and Vancouver Island, draw a circle, you know, you're going to have all kinds of mutual support groups. And by the way, I think myself, and I'm pretty sure everyone on this call, is supportive of all mutual support groups. But that being said, you know, let's think about the reality here that most Canadians don't live in Vancouver. So if someone's going to go back to, you know, Quesnel, or they're going to go back to Williams Lake or Fort St. John or Kelowna, you know, if show me another program that's free, available everywhere, and basically any day in any town in this country. You know, it wasn't long ago I was in a small town, Saskatchewan, and I found 2 meetings in one day. And it's like, you know, I'm not going to be accused of being the biggest, you know, religious follower on by any stretch of the imagination. That took a bit for me to understand too, but it wasn't something where I was so immersed in the rhetoric that it was a deal breaker. Because, you know, right away I realized, hey, I got a bunch of people here that are willing to you know, show up, you know, be open, be honest, be vulnerable, and also listen to me without judgment when I was doing the same thing, right? And to support me. And they also understood without even saying words where I was at. I think that's one of the biggest things for people in recovery. Susan talked about, you know, what is it, how hard it is to stop. I mean, people that have walked that road, have that experience. I mean, that's irreplaceable. And so, and we can say that from a service provision perspective, but the reality is, let's think of someone newly entering recovery. They are going to connect with and galvanize towards someone who they know has had a very shared similar experience, that they know can speak on the same language. And I've never, you know, not just in the addiction community, but I've never seen, you know, really a predictably reliable group, no matter what geography I'm in, that I can show up, be accepted, be understood, you know, be confidential if I so choose, and move on. And also, it didn't cost me a dime. And if I can get over one component, which, you know, it's very, very easy for me to get over, given that the benefit I've received from it, and that's great. And I think that the steps as well, I mean, with the giving it back components is a very important process. And I think if you borrow from, you know, the literature on how people learn, right, you know, one of the best ways to learn is to teach. And so, you know, providing and giving it back, there's more to it. That's not just a self-serving step. That's also a step in everyone else's, your own recovery. So, I don't see the rationale to it. I think I'm very open. We'll provide mutual support groups for Smart Recovery, Women in Recovery, Refuge, you name it. Doesn't much matter, but I just know that the availability doesn't exist. And so we're fighting an uphill battle that, it's fighting gravity.
Well, thank you, Carson, on that note. I think we've all learned our lessons. Historically, there have been some mistakes made. And I mean, I know pretty much every treatment center in Canada, not all of them, but almost all. And I don't know of any that doesn't practice, you know, medication-assisted therapy and has a physician. And there may be some, but we're hoping to improve upon that with more conversations like this. And building friendships and allies with all the different stakeholders. I wanted to bring Jessica in to see if she has any questions or comments.
Sure. I do want to do a point of clarification that there are both private and funded programs, support recovery programs, treatment centers that require people to attend mutual support groups, and others make it optional. So if people assume that it's a one-size-fits-all, we are making changes in that. I do want to thank Gloria and Leslie for using people first language about if this is what someone wants to do right now, there should be options available. We need to offer all the supports rather than talking about labels such as readiness or a judgment of willingness or terms like surrender. I really do appreciate that you continue to model that openness and that compassion, that people, it's ultimately their choice, and we're not here to judge what that choice looks like for them. So thank you for that. I guess my question is, I just want to acknowledge anyone on this call that has lost people over the last couple months, as I know we all have. If anyone who is listening is currently using substances behind closed doors or locked doors, there's apps that are available. There are multiple resources that you can utilize that can support you in staying alive. And I really want to encourage you, we'll add those to the slide deck, that you consider using them, because we do want people to continue being alive. And if you have lost people, like Leslie mentioned, Mom Stop the Harm, you have support available to help you on that path. My questions is looking over the next 5 years, what do we need to be focusing on helping people who use substances and that are seeking recovery? And those aren't, and it's not an either or. Some people seek recovery, some people are managing their substance use. For the next 5 years, what are the key messages and key efforts that we need to focus on here? And that I want to open that up to the panel as a whole.
You're on mute, Leslie. There you go.
One of the efforts that I would love to see, and I know in different parts of the country and even of the province, people are attempting to do this, but a website or portal that is constantly updated on where those beds are available and how they could be accessed. And believe me, I believe the governments on all levels should be subsidizing beds to the nth degree. Every bed should be available, and no one should have to wait, and all of those things. But a portal that would either be provincial for each province or even regional, where a person could just go on a website, boom, here's a bed right now, or tomorrow. So those kinds of portals, those they're not impossible. They're difficult. They take a lot of management and they take funding. But I just think that would be great. One thing that I wanted to say before, and I forgot, and this is around the risk mitigation, safer supply issue, that this is never meant to be a treatment. It's never meant to be a treatment. It's never meant to be something that will definitely lead someone into treatment or anything. It's just simply to keep people alive. And so we wouldn't, as I guess I actually already said that, but you know, we want people who need to access the information to be able to at those points. And I think we're moving in the right direction in the province. The rollout was rocky, still is, but there's a team of people working to expand and to let people know that, you know, this is harm reduction, but it is not the end of, it's not the end of the path.
Thank
And
you,
I have
Leslie.
a follow-up question for Julian around your navigators or recovery coaches. With the implementation of health authorities and other programs utilizing navigators, is there any research that has come up or program evaluation that has pointed in the direction of it being beneficial to people who use substances or those seeking support for their recovery journey? Or is it too early to tell?
So there's effectiveness. There's evidence of effectiveness of the role of navigators in several areas, not restricted to addictions. And the key is where are you navigating? So in BC, my understanding and the results of audits and reports of others is that we are very deficient in appropriate resources to assist people, especially across the what would be a recovery journey, starting from homelessness, exclusion, involvement with the courts, through to something transformational. We don't have those resources, and as a result, I'm unsure how much navigators will be able to do on their own, other than discover for themselves and their clients and raise the flag in their health authorities that we don't have all the things I need to help people.
Okay, we are definitely short on time. So the conversations here are very strong. I'm hoping I can ask permission on everyone that's attending that we can maybe go a couple minutes longer just to get the Q&A part and closing summaries complete. So hopefully you'll do that. We won't take too much longer. I'm going to ask Amanda to come back and start with the Q&A portion.
We've got quite a few questions in here, so my apologies if we can't get through them all. We do so highly appreciate your engagement here. I will kick us off. So back over to you, Julian. I've got a question here that says, harm reduction as a philosophy and practice is and can be recovery. If recovery does not mean abstinence only, then why is recovery continually framed as a step beyond harm reduction?
Well, so it's been framed as I've learned it as framed on a continuum with harm reduction. And the way my mentor, Alan, this is Alan Marlatt, who wrote the book Harm Reduction, would say it, is that abstinence is objectively the condition of lowest harm. So there you go. It's not a dilemma or I mean they're one and the same. They exist on a continuum of reduced harm.
Great. Another question here, maybe for Carson. Many recovery centers are, or maybe not many, but there are recovery centers that are slow to take up managed medication-assisted treatments. What movement is taking place to address the diversities of pathways in recovery? Oh, you're on mute.
Carson.
There we go. Yeah, no, Giuseppe touched on it. I mean, again, the lack of an authoritative or oversight body, we don't have that. This is all anecdotal information, but including that question, the inference of it. But the reality is, I would say any of my colleagues and peers in this field, they are doing that, but there's a deeper question that really has to get talked about, which is what is evidence? What is the evidence? Because we push so hard, so intentionally, and form follows function. We talk about harm reduction, and Leslie's a dear friend, but the platform of Moms Stop the Harm has been very influential in that regard, as amongst many others. But the data, it's like, as Julian said, there's a misread of the data, right? If these things are a must, if this is one of the criterion for it, I think one of the more important or reflective criteria would be the evidence-based practices by the medical and clinical teams. But, there's this inference based on the way that we advocate for policy that we ought to be doing something, right up into the point where it might not be in the best interest of the person receiving it. And that to me is a very, very dangerous spot to be in. The retention rates for OATs are not what, they're a lot lower than people think when you have these conversations, and they mimic more of what nicotine would say than something that's curative. But again, the idea that we're going to perpetuate or prescribe our way out of a problem that we largely prescribed our way into, we've shown ourselves that, just look at history. We've tried this many times and it hasn't worked. So.
Yeah, and maybe a follow-up question to that, Carson, in helping people explore their options in this continuum of care, ensuring that if they choose to be on medication-assisted treatments, that those are available to them in recovery centers. What's the movement there?
Yeah, my understanding, and as a British Columbian, I would say I'm proud to say that is available to anyone that's there. There's medical engagement with residential facilities, all of the ones which I'm aware of, which I believe would be most in the province. And I think that if that is such a choice, my last point I'd just like to make is I hope that that's an informed choice that the patient and the clinician make together collaboratively. Reflective of what we have for evidence, but also the context with which someone is going to recover in the community.
So this question, it says it's for anyone, so feel free to jump in. How do we feel about unlicensed recovery houses where the staff are financially benefiting from private funded clients? Giuseppe,
I think that the creation of Addiction Recovery Association can point in the direction of how we all feel about Canadians accessing appropriate care that is not going to take advantage of them when they're vulnerable, or the families when they're vulnerable. So I think we really need to continue to make leaps and bounds when it comes to licensed, regulated services as a whole for people who use substances and that are in recovery. And that goes as far as illegal suites, working under the table, all of these things that are regulatory, unmonitored, that are people that I access they don't get paid paychecks when they believe that working under the table is their only option as far as employment because of their history with substance use. So I think we need to continue to address those issues, because they impact us all.
For just a quick comment on that, we see with COVID in Vancouver, where we have the ability to access millions upon millions of dollars for COVID responses, turning the convention center into a makeshift hospital. It would be nice to see the government, access that money as well in regards to the addiction and overdose crisis that we have. We have the ability, but for some reason, we don't have the ability to shut down or moderate all treatment facilities and services for addiction and mental health. And I think that's because there hasn't been an equal amount of respect to that type of field, and there should be. It's killing more people. And it would be nice to see the convention center turn into an addiction treatment center for people that have addiction, not sit empty waiting for people with COVID. I think the response to COVID is important, but it also shows the lack of response to addiction, not just in BC, but across the country. So I know we can do it. There's accreditation services that can be done. There's so many ways to do it, but yet it seems to still not be taking shape.
Thank you. And so recognizing we're a little over time, so I apologize that we can't take more of those questions, but as always, we'll be reviewing those questions and seeking opportunities to provide an FAQ report or a little bit of a report summary so we can get to the questions we were unable to answer. But we did want to come back to this slide here. Jessica referenced to this. Here are a bunch of resources that we think will be really helpful for you to access. Of course, if these resources aren't meeting your needs, please do email us and we can direct those appropriately. On behalf of Giuseppe and I, just wanted to thank the presenters and panelists here today for your time and this great discussion. We hope that this momentum will carry forward into part 4 happening next Wednesday. But with that, we say thanks for joining us. Thanks to our panels and have a great rest of your day.
Okay, thank you, everyone.
Thank you.